Pneumonia is due to inflammation of the lung alveoli from an infection. Typically, fluid that's filled with white blood cells starts to fill up the alveoli. And that inflammatory fluid essentially replaces the air that's normally in the alveoli. And that fluid interferes with gas exchange. Pneumonia typically causes a fever, cough, and shortness of breath, along with tachypnea and tachycardia, and occasionally hypoxemia. If the infection is near the pleural surface, it can cause pleuritic chest pain, which is pain that worsens with inspiration. On chest exam, there's dullness on percussion, increased tactile fremitus, which is an increased sensation of vibration when palpating over the affected area and asking the individual to speak, and agophony, which is increased resonance of transmitted sounds and makes the letter E sound like the letter A. On auscultation, bronchial breath sounds or inspiratory crackles might be heard. The diagnosis of pneumonia is based on having clinical signs and symptoms along with abnormal chest imaging, most commonly a chest X-ray. In pneumonia, a chest X-ray typically shows either a lobar consolidation or a diffuse interstitial infiltrate. Pneumonia has to be distinguished from atelectasis, which is when there's collapse of a region of the lung, a complication that often happens in individuals after surgery. On a chest X-ray, atelectasis shows up as a wedge-shaped region with its apex at the hilum, with an ipsilateral shift of structures due to volume loss. In contrast, in a pneumonia, there's usually normal or increased volume with a consolidation that doesn't have an apex at the hilum, and no shift in structures. Now, in addition to imaging, some lab tests suggestive of pneumonia include an elevated white blood cell count and elevated markers of inflammation, like procalcitonin and C-reactive protein. It's thought that these generally increase much more in bacterial pneumonia versus viral pneumonia. For individuals with pneumonia, the next step is to figure out the setting in which the pneumonia developed. If the pneumonia was acquired anywhere in the community, but not in a hospital, it's called community-acquired pneumonia, or CAP. CAP can develop in anyone, but most commonly affects the elderly and individuals with underlying diseases, like chronic obstructive pulmonary disease, or COPD, as well as alcoholism or smoking. If the pneumonia was acquired more than 48 hours after admission to the hospital, it's called hospital-acquired pneumonia, or HAP, or HAP. Finally, a subgroup of HAP called ventilator-associated pneumonia, or VAP, refers to pneumonia that was acquired more than 48 hours after endotracheal intubation. In the majority of cases, antibiotics are selected based on the most likely pathogens in a given situation, and this is called empiric coverage. The initial step in managing CAP is determining whether an individual should be cared for in an outpatient, inpatient, or intensive care unit, or ICU setting. One set of criteria is called CURB 65. The C is for confusion, U is for uremia, defined as a blood urea nitrogen, or BUN, greater than 20 milligrams per deciliter. R is for a respiratory rate greater than 30 breaths per minute. B is for systolic blood pressure below 90 millimeters of mercury, or a diastolic blood pressure below 60 millimeters of mercury. And 65 is for the age of 65 or older. Each positive criterion is given 1 point, and individuals with a score of 0 or 1 are generally treated in an outpatient setting. Those with a score of 2 are treated in an inpatient setting, and those with a score of 3, 4, or 5 are treated in an intensive care unit, or ICU. Sputum and blood cultures are not usually sent in the outpatient setting. However, they're both sent in individuals going to the intensive care unit, and should be sent for certain individuals in the inpatient setting, like those with cavitary infiltrates and those with alcohol intoxication. Curb 65 is popular because it's fairly straightforward and easy to apply. But there are other more elaborate scoring systems like the Pneumonia Severity Index, which takes more into account like vital signs and an individual's comorbidities. So let's say that an individual will be treated as an outpatient. If that individual has no comorbidities and also hasn't been on antibiotics in the past 3 months, then they can get an oral macrolide like azithromycin or oral doxycycline. However, if the individual has comorbidities like chronic heart, lung, kidney, or liver disease, asplenia, which is functional or anatomical absence of the spleen, immunosuppression, or if they've used antibiotics in the past 3 months, then they're more likely to have an antibiotic-resistant pathogen. So in these situations, the individual should not get started on an antibiotic that they've recently taken. These individuals are treated with either a combination of an oral beta-lactam, like amoxicillin clavulanic acid plus a macrolide, or monotherapy, with an oral fluoroquinolone like levofloxacin or moxifloxacin. However, since ciprofloxacin doesn't reach high enough levels in the lungs to be effective, it's not an option here. If an individual needs to be treated as an inpatient, then one treatment option is with an intravenous beta-lactam, like ceftriaxone, cefotaxime, or ampicillin, along with a macrolide or doxycycline. An alternative treatment approach is monotherapy with an intravenous fluoroquinolone like levofloxacin or moxifloxacin. Finally, if an individual needs to be in the intensive care unit, then they're typically treated with a combination of an IV beta-lactam plus either a macrolide, doxycycline, or fluoroquinolone. If an individual in the ICU might have Pseudomonas aeruginosa, then an anti-pseudomonal beta-lactam should be used, like piperacillin tazobactam, ceftazidime, or cefepime. And if an individual might have methicillin-resistant Staphylococcus aureus, or MRSA for short, then vancomycin or linezolid should be used. Now, although empiric antibiotic coverage is mainly based on the treatment setting, the diagnostic workup and empiric antibiotics can differ a bit based on the organisms that are suspected, based on the appearance of the chest X-ray. One appearance is a lobar pneumonia, which is where a lobe of the lung is involved and often there are air bronchogram. That's where the alveoli are opacified, or white, and the nearby bronchi are filled with air and appear dark, making them easier to see. Overall, the most common cause of a lobar pneumonia is Streptococcus pneumoniae, and when it's suspected, a pneumococcal urine antigen test can be done to confirm the diagnosis. Other pathogens like Haemophilus influenzae and Moraxella catarrhalis are sometimes seen in individuals with chronic obstructive pulmonary disease, or COPD. Another specific cause is Staphylococcus aureus, which typically causes a post-viral pneumonia. That's where an individual with viral pneumonia, like from influenza, will be on the mend, and then will suddenly get sicker. That's because the virus damages the epithelial lining of the lungs and makes a bacterial superinfection with Staphylococcus aureus or Streptococcus pneumoniae much more likely. One group of individuals that develop recurrent pneumonias are those with cystic fibrosis, because the thick mucus in the airways impairs microbial clearance. Common organisms implicated in cystic fibrosis include Pseudomonas aeruginosa, Staph aureus, and Burkholderia cepacia. Another appearance is a diffuse interstitial pattern on a chest X-ray. Bacteria that cause this appearance are called atypical bacteria, and they include Mycoplasma pneumoniae, Legionella pneumophila, and Chlamydophila pneumoniae. They're atypical because they're difficult to grow using standard culture methods, occur in younger adults, and cause milder symptoms. This pattern is thought to develop because the inflammation is localized to the interstitial walls of the alveoli, but not the alveolar space. Mycoplasma pneumoniae classically develops among young, healthy individuals who live in close contact with one another like soldiers in military barracks. Mycoplasma can also cause some unique extrapulmonary findings, like bullous laryngitis, which is a blistering infection of the tympanic membrane, as well as autoimmune hemolytic anemia, due to the formation of IgM antibodies that agglutinate when exposed to cold temperature. Legionella tends to happen in individuals exposed to contaminated water sources, like hotel air conditioners or water tanks on cruise ships. Legionella can also cause extrapulmonary symptoms like relative bradycardia and hyponatremia. Relative bradycardia is where the heart rate stays the same even if there's a fever, which is an unusual pattern. Hyponatremia is thought to be due to syndrome of inappropriate antidiuretic hormone, or SIADH, which causes excess water to get reabsorbed by the kidneys. If Legionella is suspected, a Legionella urine antigen test can be done to confirm the diagnosis. Finally, there are some animal exposures that put an individual at risk. For example, exposure to farm animals and their secretions increases the risk of Coxiella burnetii, also called Q fever. Also, exposure to birds like parrots is a risk factor for Chlamydia psittaci. Exposure to mouse droppings in urine is associated with hantavirus, which can cause fever, pneumonia, and renal failure. Additionally, fungal pneumonias tend to happen in certain geographic areas. For example, histoplasmosis, which is caused by Histoplasma capsulatum, is found in Ohio and the Mississippi River valleys in the U.S., and is associated with exposure to soil contaminated with bird and bat droppings. Individuals present with fever, weight loss, night sweats, pneumonia, pancytopenia, hepatosplenomegaly, and generalized lymphadenopathy. Blastomycosis is located in the upper Midwest, like Wisconsin. Individuals often present with pneumonia, skin lesions, osteomyelitis, and genitourinary involvement like prostatitis. In general, mild cases of histoplasmosis and blastomycosis are treated with itraconazole, while disseminated cases are treated with amphotericin B. Also, influenza A and B and many other viruses can cause a viral pneumonia, particularly in the elderly or individuals with chronic lung disease. This results in acute worsening of symptoms and a bilateral diffuse interstitial infiltrate on chest X-ray. This is in contrast to a post-viral bacterial pneumonia, which tends to cause a lobar consolidation or cavitation. Alright, moving on to HAP and VAP, both of which are caused by organisms that are generally more antibiotic resistant, like gram-negative bacteria like Pseudomonas aeruginosa, Klebsiella pneumoniae, and Escherichia coli, as well as gram-positives like methicillin-resistant Staphylococcus aureus or MRSA. In addition, HAP or VAP affects high-risk individuals that are generally older, often have lung disease, and are immunocompromised. And in the case of VAP, have been ill enough to need mechanical ventilation. A sputum culture from the lower respiratory tract is particularly helpful because it's more likely to reveal the pathogen. The culture can be obtained by doing a bronchoalveolar lavage. In a bronchoalveolar lavage, a flexible tube that's attached to a camera is placed down the trachea and fluid is suctioned out of the lungs. Alternatively, an endotracheal tube sample can be obtained if the individual is intubated. Once the sample is obtained, it can be sent off to the lab for culture and gram stain. Individuals with HAP and VAP are inpatients or in the intensive care unit and should be treated with empiric antibiotics that cover gram-negative rods like Pseudomonas. Therefore, options include a cephalosporin like ceftazidime or cefepime, a carbapenem like imipenem or meropenem, a monobactam like aztreonam, or piperacillin tazobactam. In addition, we need to add another antibiotic that covers MRSA. Therefore, we add either vancomycin or linezolid. Now, if the cultures come back negative, discontinue the antibiotics and think about another cause of their symptoms. If the cultures are positive and the individual is clinically improving, then narrow the antibiotics according to the culture results. But say the cultures are positive, however the individual is not getting better. In such a case, you should evaluate for a complication like an abscess or a parapneumonic effusion. Now, one specific type of pneumonia is aspiration pneumonia, and it typically happens among those with an impaired swallowing mechanism, like individuals who are intoxicated with alcohol or individuals with neurological dysfunctions like those with a stroke. These individuals can aspirate foods and liquids as well as their own secretions, bringing oral flora deep into the airways, causing the aspiration pneumonia. Aspiration pneumonia can happen in both a community and hospital setting, so it's usually a cause of CAP or HAP. The infection is often polymicrobial, often including oral anaerobes and gram-negative bacteria, and that can lead to purulent, foul-smelling sputum and formation of a lung abscess. If the individual was upright when the aspiration happened, it most often affects the right lower lobe. And if the individual was in a supine position, then the posterior segment of the right upper lobe is most often affected. Now, whether it's a CAP, HAP, or VAP, pneumonia can result in some complications like parapneumonic pleural effusions and lung abscesses. Sometimes the inflammation from the pneumonia can result in a parapneumonic effusion, which is when there's inflammation of the pleural space that results in a pleural effusion. Oftentimes, the chest X-ray might show a cavitation with an air fluid level, and that suggests that some of the infection has been walled off and has formed into a lung abscess. Unlike most abscesses in the body, lung abscesses can sometimes get treated without drainage and simply with a prolonged course of clindamycin, which covers the anaerobes, and vancomycin, which covers MRSA if it's suspected. When it comes to effusions, a sample of the pleural fluid should be taken by inserting a needle through the chest wall, a procedure called a diagnostic thoracentesis. Now, a parapneumonic effusion is often sterile, meaning a gram stain and culture of the fluid are usually negative. If the effusion is small and the patient is not in respiratory distress, then it typically resolves with antibiotics only. However, if the effusion is large, or the individual is hypoxic or in respiratory distress, then in addition to giving antibiotics, an ultrasound-guided therapeutic thoracentesis should be done to ease symptoms. In contrast to a parapneumonic effusion, an empyema happens when bacteria have invaded into the pleural space. Empyemas are often loculated and full of bacteria, pus, and adhesions. If the pleural fluid sample shows a positive gram stain and culture, has a pH of less than 7.20, or has a glucose level below 60 milligrams per deciliter, then that indicates that it's an empyema. In addition to a more prolonged antibiotic course, empyemas need to be drained using a thoracostomy or chest tube. Video-assisted thoracoscopic surgery, or VATS, which is kind of like a laparoscopy of the chest, can be used to surgically drain more complicated empyemas. Fortunately, there are vaccines that can help prevent pneumonia. There are 2 pneumococcal vaccines, which protect against Pseudomonas pneumoniae. There's 13-valent pneumococcal conjugate vaccine, or PCV13, which covers 13 different types of Streptococcus pneumoniae. And the pneumococcal polysaccharide vaccine, or PPSV23, which covers 23 different types. Any adult 65 years or older should be given the PCV13 vaccine, followed by the PPSV23 vaccine 6 to 12 months later. This sequential vaccination method can also work for high-risk adults less than 65 years, like those who are immunocompromised, have asplenia, sickle cell disease, as well as those with cerebrospinal fluid leak, or have a cochlear implant. In addition, the PPSV23 vaccine should be given alone as a one-time vaccine to adults less than 65 years old, who are current smokers or have chronic medical conditions like diabetes, heart, lung, kidney, or liver disease. Finally, all adults should get the inactivated intramuscular influenza vaccine annually to prevent viral pneumonia from influenza. Now, in addition, some specific ways to prevent aspiration events leading to HAP include keeping the bed elevated at least 30 degrees and limiting usage of nasogastric tubes. And one way to help reduce the risk of VAP is to wean intubated individuals off the ventilator as soon as possible. Alright, as a quick recap. Pneumonia is diagnosed based on symptoms like cough and fever and an abnormal chest x-ray, which might show a lobar consolidation or an interstitial infiltrate. In some cases, there might be a cavitation or pleural effusion. Pneumonia is classified into community-acquired pneumonia, or CAP, and hospital-acquired or ventilator-associated pneumonia, or HAP and VAP. CAP is defined as a pneumonia in which the organism was acquired anywhere in the community outside the hospital. HAP and VAP are defined as pneumonia starting more than 48 hours after admission to a hospital or endotracheal intubation, respectively. Decision-making tools like the CURB-65 are used to determine whether CAP should be treated inpatient, outpatient, or in the intensive care unit, and the antibiotic choice depends on the setting. Sputum samples for gram stain and culture, as well as blood culture, should be obtained for individuals with CAP in the intensive care unit, as well as those with HAP or VAP. Complications of pneumonia include parapneumonic effusion, empyema, and lung abscess. Preventative measures to decrease the risk of acquiring pneumonia include providing the pneumococcal and influenza vaccines.